Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Viewers, today we shall discuss the second case history of hepatitis B. It is taken from the daily clinical practice. We shall see how to manage this patient in the light of guidelines available to us. Bismillah ar-Rahman ar-Rahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. We are in the management of hepatitis B workshop with the aim of translating guidelines into everyday clinical practice. And today is the case history number 2. A 32 years of old female having 2 kids found to be HBs antigen positive on workup for non-specific myalgias. No family history of hepatitis B or liver malignancy. BMI 28.1. Rest of physical examination is unremarkable. Her investigations show hemoglobin 13.7 gram, MCV 84 femoliter, platelets 335,000, WBC 7.6, bilirubin 0.8, ALT 30, that is normal, AST 34, again normal, alkaline phosphatase 125, again normal. Her albumin was 3.5 gram within normal range, globulin 3.1, again within normal range, INR 1.02, prothrombin time 11 seconds, urea 22 milligram, and creatinine 0.64 milligram per deciliter, all normal. She was having anti-HDV total non-reactive, anti-HCV non-reactive, anti-HIV non-reactive. Her HBV DNA PCR was 140,000, that is 140,000 international units. She was having HBe antigen reactive and anti-HBe non-reactive. Her abdominal ultrasound showing liver shows normal echo texture, regular margins. Spleen is 14 centimeter. Spleen size is 8.5 centimeter and portal vein diameter is 9 millimeter. That is, it was normal. Her FibroScan score was 7 kPa and EPRI was 0.226, that is less than 1. So she was HBe antigen positive, chronic hepatitis B with PCR 140,000, and she was having a normal liver and on maximum F1, F2 fibrosis. So the question for you is, how will you manage this case? Option A, serial ALT every 3 months. You will do serial ALT every 3 months. You will go for liver biopsy. You will treat with nucleoside analog. You will repeat FibroScan after 6 months. And E, you will advise on weight loss. So please write down your option. If you think you will do serial ALT every 3 months, your option is A. If you will go for liver biopsy, your option is B. If you want to treat with nucleoside analog, start the treatment, your option is C. And if you want to repeat FibroScan after 6 months, your option is D. And if you want to advise on weight loss, then your option will be E. So you note down your answer. And now we see what the answer is. You start this lady with nucleoside analog. So the option C is correct here. Why? The guideline says these are the EASL guidelines, and though the guidelines which are clear and say the patient should be treated, patients with HBe antigen positive or negative chronic hepatitis B, this was E antigen positive. Patient with cirrhosis, any detectable HBV DNA regardless of ALT levels, she was not cirrhotic. She is not cirrhotic. And patients with HBV DNA more than 20,000 and ALT more than 2 times normal regardless of the severity of histologic reasons. So she's HB antigen positive. She is non-cirrhotic. Her DNA level is more than 20,000, but her ALT is normal. So she is out of this category that should be treated. She may be treated. Why I say like this? Because the EASL guideline says patients with HBe antigen positive chronic hepatitis B infection more than 32 years old, regardless of severity of liver histological lesions. So her age was higher than 30 years. That's the reason she was considered to be treated. And these are the grade 2 recommendations. There's another category in the EASL guidelines that patient can be treated if patient is HBe antigen positive or negative, irrespective of the HBe antigen status, but there is family history of HCC or cirrhosis and extrahepatic manifestation. She doesn't fall in this category. She doesn't fall in this category, but she falls in this category and she was offered treatment. The AASLD guidelines versus EASL guidelines, it is important to refer to those as well. The HBV DNA level for AASLD is more than 20,000 if there is ALT is more than 2 times and the liver disease is not applicable. But if there is a cirrhosis, then any level of DNA and any level of ALT, the patient must be treated. Rather, the EASL says if there is moderate inflammation or fibrosis, ALT must be high and the DNA level should be more than 2,000. While if there is it is more than 20,000, the ALT is more than 2 times, then the liver disease condition does not apply. But if the patient has got cirrhosis, then the DNA level as well as the ALT levels, these do not apply. So these are the difference between these two main guidelines globally. There is an article, Factors Predictive of Significant Hepatic Fibrosis in Adults with Chronic Hepatitis B and Normal Serum ALT Levels, like in these patients. And what they concluded that the negative predictive values of 68 to 68%, the HBe, the age greater than 30 years, like in this patient, grade 2 liver inflammation and lower serum DNA levels were independently associated with stage 2 fibrosis on liver biopsy. So the point is, I want to stress upon, I want to tell you is that higher the age, or greater the age, the chances of the patient having fibrotic liver disease is there. And in this patient, it was FibroScan score was 7. So it was grade F1 to F2 fibrosis in this patient. Rather, it was F2 fibrosis in this lady. Liver fibrosis cannot be predicted based on HBV DNA and ALT levels. Again, there's an evidence that the liver fibrosis, the DNA level may be low, the ALT level may be normal, but the fibrosis may be there. So what they found, persistent normal ALT levels, and the patients was having if the F2 or F4, it was in 10%, and intermittent fluctuation of the ALT, where the ALT was at times it was raised, at times it was low, 31% of these, and sustained ALT levels more than normal, it was 28%. So the point is that you should not be deceived by the ALT levels and the DNL levels. If the age is falling in more than 30 years, then of course you will go for the you may treat these patients for the with a antiviral treatment. It is important to know that in hepatitis B, the guidelines, you individualize your approach to each and every patient. This is very, very important. There's another article, the virological and histological features of chronic hepatitis B virus infected asymptomatic patients with persistently normal ALT levels. So this is HBe antigen positive patient, and this is the with the persistent intermittent elevated ALT levels and you see the patients with having F2 fibrosis, the patient having with F2 fibrosis HBe antigen negative, and here the patients with the normal ALT, 29% of the patients, they had the fibrosis, and here in HBe antigen negative, the 8% of the patients, they were having F2 fibrosis, and this stage was more than F2. So point is that the ALT level is not the true indicator of patients having fibrosis or not. The Punjab hepatitis B treatment guidelines also say that when there is the EPRI score is more than 2 or more than 1.5, you treat these patients. This is what I have translated, or I have combined all the guidelines in a simple form. Then when to treat, the main factor is the liver status. You may have the normal liver without fibrosis, F0. Then you may have a fibrotic liver, and it may range from the initial fibrosis, F1, or intermediate fibrosis, F2, or advanced fibrosis, F3, and you may have cirrhosis liver. So you do the ultrasound. First of all, you go for the clinical features. If there is no history of suggestion of hepatic encephalopathy or variceal bleed, and there is no ascites on clinical examination, it means your patient is not cirrhotic. The patient is either liver is fibrotic or normal. So when in the absence of the clinical features of liver cirrhosis, that is history of hepatic encephalopathy or presentation of the patient in hepatic encephalopathy or variceal bleed or ascites, you do the ultrasound. If the ultrasound is normal, of course, the patient liver is either without fibrosis or fibrotic. But if the ultrasound is suggestive of small and shrunken liver, splenomegaly, dilated portal vein with or without ascites, so the patient is cirrhotic. So when the ultrasound is reported to be normal, then you go for the EPRI, HIP4, and fibroscan test. If in the absence of the clinical features of cirrhosis, in the normal ultrasound, when you do the EPRI and it is less than 0.5, you do FIP4, it is less than 1.5, and you do the fibroscan and it is less than 7.5, it means your patient's liver is without fibrosis. It's purely or perfectly normal liver. But if again, no features of clinical features of cirrhosis, normal ultrasound, but now the EPRI is from 0.5 to 1.5, or FIP4 is from 1.5 to 3.5, the fibroscan score is from 7.6 to 12.5. Now your patient's liver is fibrotic. It may be F1, F2, or F3. And if there are features of clinical features of cirrhosis, or the ultrasound is suggestive of cirrhosis in terms of the small shrunken liver, splenomegaly, dilated portal vein with or without ascites, and of course, in such patients, the EPRI will be more than 1.5, the FIP4 will be more than 3.5, and fibroscan will be more than 12.5, and now your patient's liver is cirrhotic. Depending upon the liver status, the DNL levels and the ALT levels, they determine when to start these patients on treatment. So when the patient's liver was cirrhotic, it means either it was confirmed by the clinical features or by the ultrasound showing the small shrunken liver and the splenomegaly and the dilated portal vein with or without ascites, or the FP4 and fibroscan levels were high, then any detectable HBV DNA level, and regardless of the ALT levels, you start these patients on antiviral treatment. But if the patient liver was fibrotic, it means there were no clinical features of cirrhosis. The liver was reported to be normal in ultrasound, but when you did the EPRI, FIB4, and fibroscan, it told you that the patient has got fibrotic liver. So in fibrotic liver, the DNA level should be more than 2000s and ALT level should be just raised. You need just raised. And if the liver is normal, and then the DNA level again more than 2000 and the ALT should be more than 2 times. So your patient, if your patient clearly falls in any of these category, either cirrhotic liver or fibrotic liver and fulfilling these two criteria, or the patient is normal liver and fulfilling these two criteria, you start these patients on treatment. But what happens if the patient is in fibrotic liver or normal liver that and fulfills the DNA levels but does not fulfill the ALT levels? In case of fibrosis, again the ALT is normal, or in case of normal liver, again the ALT is normal. Then the EASL guidelines come into play, and they say if in this group, in this very particular group, like this our lady, if the age is more than 30 years, or if there is family history of HCC or cirrhosis, or if there is extrahepatic manifestation, you start these patients on antiviral treatment. Similarly, again, in these two categories, they meet the ALT levels, but they don't meet the DNA levels. The DNA level is low, or it is low level viremia. Then the AASLD guidelines come into play, and what they say that check the HBs antigen, and if it is more than 1000, you treat these patients. But if it is less than 1000, you don't treat these patients. So these are the ways or the guidance that how you will treat these patients. Okay, the case history continues. Patient was counseled regarding treatment, but she was not willing to start treatment. So she was offered that we should start treatment because your DNA level is high and your age is more than 30, so better we start you on treatment, but she denied. She was kept on follow-up with serial ALT and PCR monitoring. This is what we do. Her labs after 6 months showed below. The bilirubin 0.8 normal, ALT 43 a bit raised, just raised the normal, AST 34, alkaline phosphatase 125, and the DNA levels more than 200,000. So, no, the DNA level is there and the ALT is mildly raised. So, how will you manage this case now? This is 6 months after the initial presentation. If you think you will do serial ALT, it's option A. Option B, do the liver biopsy. Option C, treat with nucleoside analog now. Option D, treat with pegylated interferon. And option E, repeat fibroscan after 6 months. So kindly note down your answer. And then we will see what the correct answer is. If you think you will do serial ALT, your option should be A. If you think you should do the liver biopsy, your option should be B. If you think you should treat with nucleoside analog, your option should be C. If you think you should do the treatment with pegylated interferon, option D. And if you want to repeat fibroscan after 6 months, your option is E. I hope you have noted down your option. Let's see what the correct answer is. You start treatment with nucleoside analog. This is the correct answer now. Why? And question is that nucleosides for analog and a treatment naive patient, long-term administration of patients NA with high barrier to resistance. Preferred regimes are entacavir, tenofovir, or TAFE, and these are not recommended. Pegylated interferon for chronic hepatitis B treatment in naive patients. The guidelines, these are guidelines, says that pegylated interferon can be considered as initial treatment option for patients with mild to moderate HBe antigen positive or negative chronic hepatitis B patients. The standard duration of pegylated interferon is 48 weeks, and extension of pegylated interferon therapy beyond week 48 may be beneficial in selected HBe antigen negative patients with chronic hepatitis B. Only patients with milder disease should generally be considered for treatment with pegylated interferon. Who respond better to pegylated interferon? If the patient is HBe antigen positive, then if the patient is female, high ALT levels, low viral load, genotype A and B, low HBe antigen titers, and elder patients, older age, these are the predictors of better response to pegylated interferon in HBe antigen positive chronic hepatitis B patients. In HBe antigen negative chronic hepatitis B patients, again, female patients with higher ALT and low viral load, as well as genotype BC, they are responding good as compared to genotype D. This is what the guideline says. So, the patient was started on entecavir 0.5 milligram OD after discussing pros and cons of the therapy. At 6 months follow-up, her labs are below. So she was started on entecavir, and down the time, the 6 months, after the 6 months of her treatment, her labs were repeated, and these are bilirubin 0.8, ALT 20, AST 30, alkaline phosphatase 125, and the PCR has dropped to 2,200. It was 200,000 previously, and she at HBe antigen is reactive and anti-HBe is non-reactive. This is what after the 6 months of taking entecavir her labs are. So the question to you is, how will you manage this case? She has taken entecavir for 6 months. Her PCR has come down but still positive. So what will you do now? Option A, you continue treatment with entecavir. You start treatment with pegylated interferon. You add tenofovir. You switch to tenofovir, or you repeat fibroscan after 6 months. So if you want that you will continue with the entecavir the same way, your option should be A. If you want to start the patient with pegylated interferon now, then instead of the entecavir, your option should be B. If you want that you will add a tenofovir to entecavir, your option is C. And if you want to switch from entecavir to tenofovir, your option should be D. And if you want to repeat the fibroscan after 6 months and keeping the patient on the same, then your option should be E. So please note down your options. Correct answer is you continue treatment with entecavir as it is. And of course, monitoring is important for these patients. The guideline says that when you start a patient on entecavir, TDF, or TAFE, you should do the ALT and serum DNA levels in all patients treated with these, and you do their renal monitoring. Patients at risk of renal disease treated with any NA, especially the elderly patients. All patients treated with TDF, regardless of renal risk, their renal monitoring should be there. And you switch to entecavir or TAFE, and it should be considered in patients on TDF at risk of development and are with underlying renal or bone disease. So if the patient was on TDF and the patient has developed started renal impairment, or the patient is at the risk of renal impairment, then you can switch from TAFE, from TDF to entecavir or TAFE. The long-term surveillance in these patients is HCC surveillance. All patients under effective long-term any therapy should be surveillance should be done for HCC. And of course, the mandatory is in all patients with cirrhosis are moderate to high HCC risk at the onset of the NA therapy. So all patients, the surveillance is recommended, but if the patient is having the cirrhosis or moderate or high risk of HCC, then of course you will go for the mandatory HCC surveillance. And again, this is the Punjab guidelines, the Pakistan guidelines that you monitor these patients for the side effects. The ALT levels, ALT, BPCR, and HbS integration and Fabro score. So she was continued or entacavir. After 1 month, 1 year follow-up, her labs are below. So no, she is taken the entacavir for 1 year. And when we repeated her labs after 1 year, after 12 months of taking the entacavir, bilirubin 0.8, ALT mildly high 62, AST 55, alkaline phosphatase 120, PCR. Initially it was 200,000, that is 2 lakh, then it reduced to 2,200, and now it is increased again to 14 lakh. So there's raised in the DNA levels. HBe antigen is still positive. Anti-HBe is non-reactive. So this is her labs after 1 year of taking entacavir. So the question to you is, at this stage, when she has taken the entacavir for 1 year and her PCR value has increased, the ALT is also increased, should you increase dose of entacavir to 1 milligram? Option A, you should start treatment with pegylated interferon. Option B, you switch to tenofovir. Option C, you check for drug compliance. Option D, or you do the viral resistance testing. Option E. So if you think in such patient who has taken entacavir for 1 year, who has been on entacavir for 1 year, you have prescribed entacavir a year ago, and the ALT level has been increased and the viral load has increased. So what will you do? You increase, if you want to increase dose of entacavir to 1 milligram, your option should be A. If you want to start treatment with pegylated interferon, write down your option as B. If you want to switch to tenofovir, write down your option as C. If you want to check for drug compliance, write down your option D. And if you want to do the viral resistance testing, please write down your option E. I hope you have noted down your option. So let's see what is the correct answer. Check for drug compliance. And the reason is that in non-cirrhotic liver, 0.5 milligram and 1 milligram, they behave the same. Pegylated interferon is not really indicated over here. Switching to tenofovir as well, because switching to tenofovir means that the patient has developed resistance to entacavir. So viral resistance testing is also not recommended because the tenofovir and the entacavir, they are high resistance barrier drugs, and resistance has not been reported to these drugs. Even for 5 years, no resistance has been reported to any of the drugs, and after the 5 years, it was less than 1% resistance has been developed to entacavir, but for tenofovir, even after 7 years of regular usage, no resistance has been documented. So the fair chance that the patient has developed a resistance to entacavir, and she was treatment naive patient, so this is very unlikely. And the most common cause for the rise in the ALT and the DNA level is poor compliance of these patients. So you check for the drug compliance. This is something about the response to antiviral treatment. This is important that we understand that how we define the response of the treatment. This is for the first, just a simple way. You check the virological response on treatment. Virological response on treatment. Our patient was not on pegylated interferon, but still for on treatment, the response is when the patient's DNA level is less than 2000, we say the patient is responding. When the patient is on NA therapy, nucleoside therapy, or the oral drugs, on treatment response is defined as when the DNA level is less than 10 units, then you say the patient has responded. Primary non-response is when there is less than 1 log decrease in HBV DNA after 3 months of therapy. Then you say it is the non-response. The partial response is when the HBV DNA decreased by more than 1 log but still detectable after 12 months of therapy in compliant patients. In our patient, when we checked at the 6 months, it was a huge decrease in the viral load, and she was having the partial response by that time. The breakthrough is when confirmed HBV DNA increase of more than 1 log above on therapy netted. So, a sort of breakthrough was the case here. When you make the patient off or the treatment is stopped, then off treatment virological response will be defined as HBV DNA less than 2000 for more than 12 months after the end of the therapy, both for the pegylated interferon as well as for the NA therapy. Serological test is defined as HBe antigen loss and development of anti-HBe. In our patient, this was not achieved. And then the HBs antigen loss and development of anti-HBs, again, this has not been achieved here. In biochemical response, ALT normalization, at least every 3 months. This is when the ALT has become normal, we say biochemical response. In Our Lady, the ALT has raised. And histologically, when you do the biopsy, the histological in necro decrease in the necroinflammatory activity without worsening in fibrosis compared with the pre-treatment histological findings. So these are the different definitions of response to the antiviral treatment in chronic hepatitis B patient. So the management, what the is a recommendation is when there is any failure. In this case, though this was the poor compliance, but if there is any failure, prevention of resistance should rely on the use of first-line therapy with high barrier to resistance NAs. We started this patient on a high resistance barrier drug, and compliance to NA therapy should be checked in all cases of treatment failures. Here, the compliance was a main issue. Management of treatment failure should be based on NA's cross-resistance data. But if we have started this patient on the high resistance, a high barrier to resistance NAs, then probably this would not have been the way. And treatment adaptation should be performed as soon as virological failure under NA is confirmed. So, patient was counseled regarding drug compliance. She was continued on entecavir 0.5 milligram once a day with 3 monthly follow-up. After 2 years, her labs below. So, after 1 year, again she was her ALT was raised and her DNA level was raised, but she was counseled on the drug compliance and she committed to that. So the drug was taken for another 1 year, and every 3 months the follow-up was done. After completing 2 years of therapy, the levels are bilirubin 0.8, ALT 25, AST 24, all normal, alkaline phosphatase 110, and PCR no detected, HBs antigen reactive, E antigen non-reactive, antibody reactive. So there is HBe antigen seroconversion, and the bDNA PCR has become negative now after taking 2 years of entecavir therapy. So the questions to you is, how will you manage this case? Will you continue treatment with entecavir till HBs antigen becomes non-reactive? Your option should be A. So write down option A. Option B, if you think that you will continue treatment with entecavir for further 1 year, then consider discontinuation. Write down your option B. Option C is you will discontinue entecavir because there is HBe antigen seroconversion as well as the DNA PCR has become negative. Then your option should be C. And D, consider therapeutic vaccine. E, continue lifelong treatment and follow up with ALT and HBV DNA. So, whichever is your answer, please note down. Option A, continue treatment with entecavir till HBs antigen becomes non-reactive. Option B, continue treatment with entecavir for further 1 year, then consider discontinuation. Option C, discontinue entecavir. Option D, consider therapeutic vaccine. Option E, continue lifelong treatment and follow up with ALT and HBV DNA levels. I hope you have noted down your answer. Let's see what is the correct answer. Continue treatment with entecavir for further 1 year, then consider discontinuation. We see the HBs antigen negativity is very rare, and you shouldn't discontinue entecavir over here because now the time has not been passed after the patient being negative DNA. Therapeutic vaccine has got no role here in the clinical practice, and lifelong treatment with follow-up ALT and DNA level is probably not a better option because she is got a non-cirrhotic liver. So what the guideline says about the oral drug discontinuation? These are the EASL guidelines. Long-term therapy with NAs is usually required. HBV eradication is not usually achieved, so the NA should be discontinued. What they say, if there is HBs antigen seroconversion, with or without HBs antigen seroconversion, if the patient HBs antigen becomes negative, then you should discontinue. It can be discontinued, and our patient falls in this group. In HBe antigen positive patient, she was HBe antigen positive without cirrhosis. She was having without cirrhosis, with no cirrhosis, who achieved stable HBe antigen seroconversion and undetectable DNA and completes 12 months of consolidation therapy. That's the reason I said, no, for another 1 year, this will be her consolidation therapy, and then we can stop. And close post NA monitoring is warranted. If the patient is not willing for close post drug monitoring, then it should not be stopped. And NAs may be discontinued in selected HBe antigen negative patients without cirrhosis who achieve long-term more than 3 years virological response if closed. So this was HBe antigen positive, so this statement applies to this case. The same is the Punjab guidelines. This is from my lecture, which I had shared with you many months ago, that when to stop antiviral treatment. If the patient is on pegylated interferon, it's a defined duration of 48 weeks. Whether the patient has responded, not responded, you stop the patient treatment. If the patient is on nucleoside analogs, the endpoint depends on the hepatic and HB antigen status. If the patient is cirrhotic, has a cirrhotic liver, it's a lifelong treatment. If the patient has got fibrotic liver, it means F3, F2, or F3. Again, the long-term treatment is mandatory. But if the patient liver is normal, either F0 or F1, then depending upon the HBe antigen positive and negative status, if the patient is HBe antigen positive, as in our patient, who choose stable HBe antigen seroconversion and undetectable DNA and complete 12 months of consolidation therapy, you can think and you can stop. But in E antigen negative, who achieve long-term more than 3 years virological suppression. But of course, for these two patients, when you stop the treatment, the close post NA monitoring is warranted. So, pre-treatment predictors of response, HB antigen positive chronic hepatitis B patients, that what are those where you can say that my patient is going to respond? One is low viral load. Second is high serum ALT levels, more than 2 to 5 times of upper limit normal. If the patient has got genotype A and B, C and D are not good responders. High activity scores on liver biopsy, reduction in the HB core antigen, HBs antigen levels below 1500 units at 12 months post on patients on pegylated interferon. If the patient was started on treatment for pegylated interferon, this is the level. At week 24, HBs antigen levels more than 20,000 predict no response regardless of the genotype patient on pegylated interferon. So if the patient is on pegylated interferon, then of course the HBs antigen titers, they matter. Otherwise, these are the common predictors for the good response of the patients to antiviral treatment. So the take-home message in this case history is that if your patient presented to you is HBe antigen positive patient So all HBe antigen positive chronic hepatitis B patients with DNA level more than 2000 and LT more than upper limit normal, elastography score 8.5 or more, and APRI is more than 1.5 should be treated. This is a clear-cut stage. Nucleotide or nucleoside analogs with a high barrier to resistance in entacavir tenofovir is treatment of choice. ALT and DNA should be monitored periodically. The drug compliance should be ensured, and treatment can be discontinued if no evidence of cirrhosis and completion of 1 year of treatment after seroconversion to anti-HBe. So our patient was HBe antigen positive. She was non-cirrhotic and our age was 32. So the patient was started on treatment, and then the patient responded delayed. But no, the option is if after achieving the virological response and ALT biochemical response, if she and the HBe antigen serological response, if she maintains this for another 1 year on treatment, then the treatment will be stopped, but the close monitoring will be warranted. So, dear viewers, this was the HBe antigen chronic hepatitis B patient treatment, that how to deal with these patients in the light of the clinical guidelines available to us. So viewers, today we discuss the second case, and you realize that these patients, few patients, they respond very quickly, but a couple of these patients, they respond late. But the key is that you ensure the good compliance of the patients with the drugs, because the most common cause of no response or delayed response or even breakthrough, if you are treating these patients with entacavir or tenofovir, TDF or TAFE, is the poor compliance, because resistance reported to these cases, these drugs, is almost nil. And the second point is that you will think about the stopping of the antiviral treatment, provided your patient's liver is normal, it's not cirrhotic and not fibrotic. If the patient is cirrhotic or fibrotic liver, then you will continue this treatment lifelong. If the patient is having a normal liver and the patient is HBe antigen positive, chronic hepatitis B, then of course once the patient achieves the virological response, PCR becomes negative, and the HBe antigen seroconversion is achieved, then you give another 1 year treatment for these to these patients. This is called consolidation therapy, and then you will stop, but the close monitoring will be required. In case of HBe antigen negative, if the patient PCR becomes negative, and after that the patient completes 3 years of therapy, then you can stop these patients on the drugs. So I hope you learned the art of applying the clinical guidelines to chronic hepatitis B patients in everyday clinical practice. In the next episode, we shall discuss another case, and we shall see how the guidelines help us in management of patients with chronic hepatitis B. I stop here. Take care. So see you in the next episode. Till then, Khuda Hafiz.